Thank you, Rupert. And thank you to the conference organizers for allowing us to present this late-breaking data from ATN-110, which was an HIV PrEP demonstration study in the United States among young men who have sex with men. There are my conflicts. In the United States, gay, bisexual men who have sex with men ages 13 to 24 are those that are hardest hit by the HIV epidemic. In the large PrEP safety and efficacy trials in the United States, they were not well represented, and there's still no PrEP data to date in adolescent MSM. Additional safety and behavioral data, as well as implementation data, is really needed in young people to support any change in the PrEP indication below the age of 18. And through the Adolescent Trials Network, we have two PrEP studies, the paired studies, ATN-110, which I'll be presenting today, and ATN-113, which is still underway, looking at PrEP use among 15 to 17-year-olds. The primary objectives of ATN-110 were to provide additional safety data regarding Truvada use among HIV uninfected MSM, ages 18 to 22, to look at PrEP acceptability, patterns of use, rates of adherence, as well as drug exposure when describing PrEP as an efficacious product and with information about the safety as well, and to look at patterns of sexual behavior when young men are provided with an evidence-based behavioral risk reduction intervention, as well as information on the efficacy of PrEP. To be eligible for the study, our young men were ages 18 to 22. They had to self-report recent HIV transmission risk behavior in the last 6 months. Those criteria are listed here, and they are modeled after the IPREX randomized trial. And of course, participants had to test antibody negative at the time of screening. Just to walk you through the study flow, we recruited folks in the community at venues that served LGBT youth, as well as online and through social networking and dating apps. When participants came in then for laboratory eligibility at an in-person screening, a baseline visit reviewed those labs. Then, depending on the site that they were at, they either participated in Many Men, Many Voices, which is a behavioral group-based intervention, or personalized cognitive counseling, which is an individual level intervention. They were dispensed PrEP at week 0. They were followed monthly for the first 12 weeks and quarterly thereafter through week 48. For participants that seroconverted on study, they were followed for an additional 3 visits. And for those that met fairly conservative criteria for either renal or bone abnormality, they're being followed in an extension phase of an additional 48 weeks. Today, I'm only going to talk about the primary 48-week study, as the other seropositive visits as well as the extension phase visits are ongoing. This is just to give you a glimpse of the diverse geography of the ATN sites in the United States. And I'm not going to walk through all of the numbers of the Consort diagram to kind of highlight where people fell out, but our goal was to enroll 200 young people. We did in-person screenings on 277 young men, and just to point out that we did identify 11 previously undiagnosed HIV-positive youth, which was a little over 4% of those that we screened in person. We enrolled 200 individuals. In addition, though, at baseline, we had 2 young men who had acute infection. They were antibody negative, viral load positive, so we were able to also link them to care. We've had 58 premature discontinuations from the study, largely due to loss to follow-up and the mobile nature of 18 to 22-year-olds, some going off to college, moving for jobs, et cetera. Here are our baseline demographics. We enrolled a very diverse sample into this study, but this is a sample that's representative of the communities and the sites that the ATN locations serve. Our average age was 20. The vast majority identified as gay or bisexual, had some high school or college. About 17% reported that they had been kicked out of their homes due to their sexual orientation. 28% had been paid for sex in their lifetime. They reported an average of 5 partners in the past month, and 80% condomless sex, as well as almost 60% condomless receptive anal intercourse with their last partner. And about a fifth, 22%, had a positive STI test at baseline. In terms of safety of PrEP, we had 25 additional participants who discontinued PrEP while on study but stayed on the study, which was a choice and an option for all of our participants. Primarily, they decided that PrEP just wasn't right for them anymore based either on their risk, their relationship status, or because of side effects that they perceived to be related to the study drug, which were predominantly GI symptoms. We had 3 adverse events that we considered to be related to study drug, and those are listed there. And just to say, while I won't be presenting DEXA data because we're still analyzing it, we do have DEXA data for bone mineral density on all of our participants at baseline, 24, and 48 weeks. We had 4 seroconversions in the primary phase of our study, which calculates an incidence rate of 3.29 per 100 person years. You can see in the chart there, these are the 4 individuals and their tenofovir diphosphate levels across study weeks. Each line ends at the point of HIV seroconversion, and you can see while there were varying rates of adherence, at the time of seroconversion there was no drug detected in any of our participants, and no drug resistance found, likely because of the lack of drug in their system. STI diagnoses over time, the line here represents any STI. Again, I mentioned at 22% at baseline, but we've also highlighted here rectal gonorrhea as well as rectal chlamydia and syphilis. The low level of syphilis at week 24 is likely because we were only per protocol testing for syphilis at baseline and 48 unless participants were symptomatic. But you see what looks like a little bit of a drop off to week 24 and then stabling out, but in fact there's no statistically significant difference here, and that STIs remained relatively constant over time. Here also are some measures of sexual behavior, number of male partners, number of episodes of condomless receptive anal intercourse with last partner, number of times a condom broke during receptive anal intercourse, as well as those who were referred for PrEP over the course of the study. And again, we see here there are no statistically significant differences, that these behaviors remained relatively constant over the course of the study. In terms of adherence, what this chart is showing is by study week, the proportion of individuals that fell within the dried blood spot dosing estimates that come from Pete Anderson's lab and the IPREX data, and Dr. Liu also described this data as well. So just first to show that the vast majority, if you look at the below the level of quantification, the red here, the vast majority of our participants had detectable drug throughout the course of the study. So they were all trying to take drug at some level or not. And then we had about half the participants really in that highly protective area for most of the study until continues to drop off over time, and that's the 4 or more pills a day. And just to kind of highlight this, right here at week 12 was when we started to go to quarterly visits, and we really start to see a drop off in adherence as we move into those quarterly visits and see our adolescents and young adults less. We also have some pretty striking racial and ethnic differences. So here we have a chart showing again the tenofovir diphosphate on the y-axis across week, and this dark dotted line represents what we would consider to be highly protective dosing of PrEP at the 4 or more pills a week. This is the overall sample, which reflects the data that you saw in the previous slide. Protective levels above and through week 12, and then slowly dropping off from there. When we look at race and ethnicity, we see our white participants staying consistently above the line of highly protective PrEP. Same for our Latino participants, although dropping off a little over time. Our participants who identified as being of mixed race had protective levels for the first 12 weeks with a little dip and then back up again. And our African American participants, on average, did not reach the highly protective levels that PrEP can afford them at all across the course of the study. And regardless of race or ethnicity, all participants showed that drop off when we start to go to quarterly visits. In terms of adherence and sexual risk behavior, we did find a trend that those that reported condomless sex did have consistently higher levels of tenofovir, and there was also a trend towards those that had condomless receptive anal intercourse with their last partner, although that latter trend was not statistically significant. So in conclusion, ATN-110 was successful in identifying and engaging young men who would really be appropriate for PrEP interventions in the United States based on their self-reported condomless sex as well as the high rates of STIs. That we were able to, through this PrEP programming, identify previously undiagnosed HIV-positive youth and link them immediately to care in our HIV clinics that are youth-focused. PrEP was well tolerated with minimal adverse events, and STI diagnoses were high at baseline and remained constant over time but did not increase. Our HIV incidence rate is high compared to many open-label trials, but I would say that given the number of incident STIs, we could potentially see much higher incidence in the absence of PrEP. And those that seroconverted, to remember, had no detectable drug levels. Participants who reported condomless sex had higher levels of tenofovir, indicating that those that potentially are most susceptible to HIV are those that are most adherent to PrEP, and that adherence was good overall among this high-risk sample, but varied by race and ethnicity. And unfortunately, this is consistent with recent research, which was really showing that those that are at highest risk in this country, which is Black young MSM, have low levels of exposure to HIV prevention interventions, both behavioral and biomedical, and really a continued call for us as researchers, advocates, and policy people to really dig deep and try to figure out how we can make this work so that we're not expanding the already large gap in health disparities that we see particularly in the United States. And regardless of race and ethnicity, adherence decreased for all participants as study visits decreased in frequency, which may indicate that youth need enhanced visit schedules or maybe more ongoing contact with time, and whether that's in person or mobile technology remains to be seen. So I do want to acknowledge, of course, all of the young men that participated in this study and shared their time with us, my protocol co-chair, Craig Wilson, and the rest of the 110 team, and especially to the Adolescent Trials Network, whose work over the last 12 years building a strong community infrastructure helped to facilitate and support the communities around our sites and make this work possible. Thank you so much.
Thanks very much, Sybil. Obviously, there are some pretty powerful questions that come out of that. I bite my tongue and go to the audience. So I think you were up first at microphone 3.
Hello, Gus Cairns, AIDS Map and PrEP.